Dr. Kapil Zirpe to take this session forward with our panel discussion. Welcome, sir.
Good evening. I know we are going one by one and there is hardly any time to recover, but please be with us. I am going to give you some time. The next 25-30 minutes, we are going to discuss on a medication error, how to prevent that, how to create that patient safety. So before that, we have a very good panelists are available on board to answer our questions. And one of them is Dr. Manish Machave, who is an obstetric gynec specialist and an endoscopy surgeon. He's a chairperson of the ethics committee of the FOXI. Then we have a very senior and a respectable nurse, Miss Gracy Mathai. She's the chief executive officer at the Baby Memorial Hospital. And the third one is a clinical pharmacist. We already heard him, Dr. Jose, Chief Quality Officer and Clinical Pharmacy Advisor. So we have a good panel. I will say there is a clinician who is hardcore clinician on the ground level. He's practicing. We have a clinical pharmacist, and we have the Gracy madam. So with this, I would like to share my PPT. Just give me hardly a few seconds. I will share my PPT. And we can start the discussion and the ball rolling. Is it visible?
Yes, sir.
Yeah. I hope my panelists are now, their videos are on so that they can interact with the faculty. So I request my panelists to make their videos and audios on. So the topic is reducing the medication error and increasing the patient safety, and it must be the case-based scenario. So if I came across I came across this error is human, and to have a safe, healthy system, look at the spectrum of the medication error and the patient safety. 7% of the patients suffering with a significant medication error, 44,000 to 98,000 die from the errors, and the cost of the error is approximately $50 billion. This is, of course, the Western data. Unfortunately, we don't have such data, and I am sure in future we'll have those data with us so that we can discuss on our own. But don't blame the healthcare workers. Every time the healthcare workers are not at blame, we need to create that safe and safe care system. Everyone is responsible for medication error. It's not that ward nurse or that junior doctor who is responsible for the error and then pass on the blame for the medication error. When I start searching on medication error, because when they given me this topic, I said, let's search on the PubMed. It was to my surprise, 1,57,000 results I came across. So it is not uncommon, it is common. So with this, I would like to request Gracy madam to just enlighten us. Which are the factors that may influence the medication error at various levels, whether it is a outpatient, whether it is indoor, whether it is a ward or critical care areas? Madam.
Thank you, Dr. Kapil, for that really asking this question to me. Especially when we think about medication error, it can start from the non-compliance as well as the deviation from purchase to reconciliation. Anything you take it to purchase, your storage, your prescription, transcription, dispensing, administration, documentation, monitoring, reconciliation, anywhere deviation is there, and those are the factors. And Dr. Sunil has very clearly spelled a few factors in the before session when he has said. So I'm not going to go into detail, but I would like to few personal points when I talk about the factors that may influence the medication error, I'll divide into 5 major areas. Like one is personal, and another can be contextual factors, and the knowledge-related factors, the ward environment-related factors, and of course the management-related factors. So this way I may cut short into that. Coming to personal, like your fatigue, stress, confusion, personal and family problem, and then physician's prescription problems are over there. Errors, even though the physician has written, but the implementation problem, attention to detail is lacking in many areas from the clinician side as well as from the nurses side, and lack of job satisfaction or unpleasant workplace or related to that. or decreased sense of commitment from the people, from the healthcare workers. That's another thing. Like then inadequate experience. Nowadays turnover is very high. As you can see that not only in your organization or my organization, everywhere the turnover is very high. So that is one of the another factors. And most important, what I have seen in the personal is the mood problem of the healthcare worker. It can be a nurse or it can be a doctor, or what happened to their home, and with that they come over here. So that mood problems will be there. Again, healthcare related, health related, and their own health related or life related problems, that can another thing will be there. And always we rely on our memory. We don't refer. That's another. We feel overconfidence. So we rely on our memory, and in that memory things may not be appropriate. So we won't go into reference. And then, of course, performing complicated calculations without double checking. So these all come into personal one. When it comes to the contextual, especially the competent and skilled personnel are there. That's one of the major problem I am facing. And then overtime, long working hours, crowded unit, and where there is a necessity of an intensive care unit, what will happen? Those patients have been put into the floor and asking the nurses to take care of those patients, because intensive care charges may be more. What I am talking about is from my own organization, maybe something different in your organization. So patients are put into the floor and say, okay, doesn't matter, all lines are over there because ICU charges may be more. So the clinicians will bring over here. You can imagine what a nurse who is taking care of 5-6 patients can do in such an area. So that's another thing. And then our own hospital protocol, we neglect many people because lack of the time or lack of awareness because of all those things. Then one another look alike, sound alike, but I put talk over here, sound alike and spell alike patients, SASA, SA. Like same name patient are admitted next to one after another. Again, there can be more chances of medication error and failure to check the patient's identity at every administration, not only administration, at every stage like that. And outdated apothecary, that what we use, like maybe some calculations are of pound or grams, what you have used in the olden days, that also will be used by some of our senior personnel, and that become a complicated thing over there. Like there may not be any sufficient support staff, or supervision may not be adequate. And nowadays in the EMR, one of the major things, like when you put that 3 letters, so the drugs will come and you click whichever it comes on your way. And the 3-letter click, it's really a problem because they don't go into, that with that so many drugs are there, they cannot go to every drug. So they click whatever comes, and then a wrong medication is being there. And then multitasking, poor safety culture, that's one of the another thing. So people don't have that poor safety, don't have that safety culture. Rather, the organization also not emphasizing to have a proper safety culture. I know that some of the accredited hospital, they may be having, but mainly it is not there. Coming to the third factor, like it's knowledge related factors, like again, inadequate pharmaceutical knowledge and experience. Especially last 2 years, we have COVID batch. I call the nurses a COVID batch. From this COVID batch nurses, when you take, when you appoint them, even maybe from the clinicians also, doctor side also, when you appoint, they have less opportunity to go to the ward. So you can imagine what they know to give to you. So they have only that written or rather verbal online classes what they have attended. The other things are not over there. So that they lack in experience and they lack in knowledge, especially the pharmacological or pharmaceutical requirement. So no awareness about the patients and drugs, mathematical calculations, unawareness about the new brands of medication, lack of awareness about the route and dose of administration, lack of knowledge of preparation as well as the administration procedures, what is happening. And of course, training opportunities are also not there in their organization. So that becomes a few of the knowledge based. Then coming to the fourth one, the ward environment related. Ward environment means heavy workload are there, lack of required equipments are there. Again, they are worried in that particular type of thing. Similar drug name and the label, similar packaging. So which when they took it out, like your look-alike dress, when they took it out, there will be a problem. Arrangement of the shelves, what the people are doing, labeling what they do in their ward, that also, or their protocol, what they follow.
Sorry to interrupt. I know you can go on for 30 minutes.
Yeah.
Because so I
Okay.
choose you. You are the only right person to speak on this. So,
So
can you
the final
nutshell?
I'll come to the final I come to the management related, like what is our policy on verbal order, what is our policy on a multi-drug requirement, how we are going to do that multitasking, or what is our policy on reconciliation. Are we emphasizing all our doctors that they have to reconciliation of the medication have to be taken place at every transition phase. So all those things are the main factors apart from what you can say that common from starting from the storage to reconciliation. Thank you.
Yeah, I know, madam, that you have almost touched everything. And your hospital and my hospital is not different, and no hospital is different than any hospital. All we are working in the same environment. We are working in India, whether it is south, east, west, it doesn't matter. All administrators are same. All problems are at the ground level. So thanks for almost touching the each and every point. So we'll move on, and I'll come back to you in a due course. Not necessarily with the questions. Might be that I would like to know your experience in further. Now, we'll start with the case. This is to the Dr. Jose. This was a case we recently came across, very recently in the last week. I have taken the all real-time cases. The 60-year-old lady admitted with the CVA with history of difficulty in breathing, fever, difficulty in deglutition, typical CVA with aspiration pneumonia, community acquired. She was treated with the IV piperacin, tozobactam, oxygen therapy, supportive medication. She improved, and we are about to shift her out. The most errors are picked up by the way, the errors are picked up by the junior doctors most of the time. They are doing the medication errors, but they are picked up by the junior doctors. So that junior doctor came to me and said that, sir, it was written as an allergic to penicillin and piperacillin, and already patient received the piperacillin. Now, when I check the cross-check everything, the discharge card, the diagnosis, the private discharge card, nurse's note, casualty note, everywhere it was very clearly written allergic to piperacillin. And somehow she received the piperacillin tozobactam and doesn't happen. Okay, that's what we are very lucky. I am not defending that. So what type of this error?
Hello, sir.
Hi, yes, Jose.
Sir, it is a prescription error. First of all, it can be, in my opinion, I would consider it as a series of errors. First of all, the allergy has been noted, and the prescription and the drug has been prescribed. So, according to the NCC MERP scale, it is category 3, and medication error has been occurred, and it has reached the patient with no errors, with no fatalities or no harm to the patient. So it comes under category C. So coming to prescription error, the drug has been prescribed. So it can be prevented anyway by a sticker. We are pretty familiar with allergic stickers being pasted in our charts. But here also, allergy has been noted everywhere. But amidst of that, the drug has been prescribed. So a prescription error is one thing. And second of all, if there is a computer order entry in your hospital, when the drug is being dispensed, the pharmacy, the allergies will be showcased, and I would categorize this as well as a dispensing error as well. There is an error from the pharmacy as well. They cannot catch up this prescription error. And moving into the third category, I would like to say that there is an omission error as well. There are many healthcare staffs who are taking care of this this chart.
Yes,
and they haven't gone through. They haven't seen this allergy. That is quite a serious thing.
Yes, that's what to bring this case on the platform is omission error is one which is we missed at everyone missed at whether the casualty, whether the admission, ICU, chart, doctor, junior doctor, senior doctor, in charge, everybody. So omission error is on a last scale, then prescription, and then okay, this happening. I'm ending with the what happened to this patient and why it doesn't this thing. I don't know whether it is related with our discussion. When I went back and took the history from the patient. Patient was a nurse herself, asking, where was you notice this piperacillin tozobactam? She said, whenever I give injection to any patient, I felt itching. So then I reported it as a piperacillin. So probably it was very wrongly labeled as a drug reaction by that nurse itself as a patient. And it was carried forward by every admission and discharge. So what I mean to say, okay, no doubt it is a omission error, this is a prescription error, this is a dispensing error. We should prevent, there is no excuse for that. But please take the history very carefully. Please don't blindly follow this label as an allergic to the. We are narrowing our spectrum for that patient in future. So this is what type of this is, whether it is a omission or it is ignorance or whatever we are coming very regularly in practice, very casual approach of reporting as a allergy to amoxicillin, allergy to penicillin and meropenem. I think that's what another thing I want to specifically brought on the floor with this case. So we will go to the next case. Now, when we are seeing the drug and drug related, you will believe that the prevalence of the drug related deaths are 5.6 and the preventable deaths are 45%. So we need to aware they are preventable. You need to just take the history in properly and prevent the medication error at every level. And that's what our case is, the second case. It's to the again Gracy madam, since it is related with the everyone. 65-year known case of COPD. Patient was admitted in ward. He was on a very low dose of oxygen, and then in the afternoon time he had hypertension. BP was 60. So shifted to the ICU. We did the every management. We gave the fluid. We started the BiPAP. We settled down, and when someone take the detailed history. And when we gone through the record, we noticed that rather than tablet prednisolone, nurse had given a tablet prazopress 10 milligram. And probably that was the cause of the hypotension, but that landed with the ICU. And all of us know that ICU is not a safe environment for anyone, though I am a critical care specialist. So he later on, after 2 weeks, he had a problem with the VAP and all these things, and he succumbed. But what type of the error it was and how can we prevent? That's what the Gracy madam, and you are the right person to comment on this particular medication error. You need to unmute yourself. Gracy madam, you need to unmute. And I expect the precise answer because we need to move on with our next question.
Yes, Dr. Kapil, it's very clear that it's an administrative error. And because where the steroid is being ordered, and antihypertensive drug is being given. You can imagine what can be. And that also for a COPD patient, an old patient of COPD. See how they would have prevented it that, see, we have well-defined 10 rights for administration of medication. And if they would have followed those 10 rights, and out of these 10 rights, 5 belonging to direct medication administration and 5 belonging into indirect, but again that is a part of the medication administration, like right patient, right medication, right dose, right route and right time. All these are very clearly related to the patient itself, but that has been not looked into. That right medication, that is not looked into over there, and then this has been given over there. And again it comes to another 5 rights also. When I say that's your right to education, because when you see a drug and you have to educate your patient, what is the outcome of these drugs? What do you expect from this particular drugs after this is being given? And here I think that is also not given because they have given a wrong thing. And right documentation, when they document also, they will see that what the doctor have written and what they have given and what they will be documenting later part of administration, that also have been missed in this. And we also should know that a patient have the right to refuse. Patient have the right to refuse any medication or other care, whatever you give in your organization, and that right also have to be respected. So here already a patient COPD, maybe in various drugs he or she may be taking over there, and then they have come over here, and this patient suddenly have reduced their BP, is fallen down, and ultimately end into the ICU, and as you said, succumb to WAP. So that particular thing is the accountability. of that particular nurse as well as the doctor was not shown over here. That is their accountability. When they treat to anyone, they should have the knowledge and they should have the accountability, and that they have not done. Again, assessment of the patient. That's another important, one of the right. After certain things, after giving any medication, you have to assess that you have given this medication maybe for one reason, and you see that whether that reason the outcome have been achieved. If you do not achieve that outcome, then you can look back and say what went wrong, why I have not achieved that. Here, that also they have not looked into that. And then right to evaluation, that's the next thing. So evaluation means outcome of the medication, evaluate the patient condition, whether we need to change the drugs from what I have given earlier from the prescription. None of those things have been seen over here. So it's a drastic mistake of administrative error by the nurses. But I will say it happened within not one day. It happened within 1 week. So the doctor also would have been seen this at the early stage so that this patient would not have ended into warp and death. That's what I think.
Yeah, I completely agree. We should not develop the blame environment. We should not always blame the nurses, ward nurses. Where was the doctor? Whether you are saying the administration error. I'm adding, why not it is a prescription error? Probably the doctor's handwriting was not proper enough to, like this happens 15-20 years back. Can you imagine at that time how doctors were disciplined to write? Like one of the presentation, he said that he took time, that he noticed that it is upside down prescription. And we were proud at that time that our handwriting is nobody can read. So I think blame-free environment. I am against every time the nurse cannot be at the receiving end. So it might be the prescription error, it might be the administration error. And the most important thing, you need to evaluate whatever the drugs you have prescribed, whether it is added into the patient's comfort. That means why you like after giving the steroid, whether his breathlessness came down, whether he had some improvement after giving the steroid. So probably these are the learning point, but I would like to state that we should develop the blame-free environment. Informative culture, just whatever happens, just inform. No, we are not going to take action. We are going to educate, train, and develop the safe environment for the future. That's what the whole purpose of bringing this case on the floor. And thanks, madam, for the very informative explanation. Now we talk a lot about the adverse drug reaction. There are so many papers, so many publications are there in the adverse drug reaction monitoring pattern of the adverse drug. Then we also had a publication of the incidence of the medication errors in this thing. So what is related with the adverse drug reaction and how we can prevent that? We'll go through this case. And I think Dr. Manish Machave is listening very patiently since long time. I know, sir, you are in the mood to now jump on. So this is for you. This is very typical in a medical legal case. You are expert in the legal aspect, I know. This was a recent case. This was in the last week. Only 56-year-old lady admitted for the coronary angiography with the comorbidity of the diabetes, hypertension, this thing. After giving the Supasep as a prior to angio, they give 1 dose of antibiotic. She had a cardiac arrest, resuscitated, return of the spontaneous respiration, intubated, ventilated, properly managed. Then she recovered. She's off ventilator, she's off tracheostomy, she's off everything. And with the Jesus 9, we have discharge. Okay. Relatives are saying that why test dose was not given. Now my question is it mandatory to give the test dose every time during every admission before the full dose for every antibiotic, or to only those patients who are giving some history of this thing or high risk medications you are prescribing? So I would like to know your practical knowledge and the guidance about this particular problem.
Okay, good evening, everybody. At the outset, I would like to thank Dr. Kapil, Dr. Rebecca, and everybody for arranging this fantastic, event. And adverse drug reactions, 2-3 points I'll put forward as a medico-legal consultant who also fights cases for doctors. Adverse drug reactions in the form of medication errors are taken extremely seriously in courts. We have very little defense to give in such cases. So for the previous case, I just raised my hands because there are some cases I think you should read. What the previous case was is exactly what happened in Spring Meadows Hospital versus Harjol Ahluwalia, where a small kid was admitted with fever and instead of giving chloramphenicol, IV chloroquine was given. the child landed up with cardiac arrest and then is in a vegetative state. So point number one from that case was very important, was the court told us about the principle of vicarious liability, which means that any medication error, any adverse error with respect to giving medicines, if our junior staff or junior doctors do, we are vicariously liable for compensation in the courts. Okay, so the question just now is it mandatory to give test dose every time? No, it is not mandatory to give test dose every time for medicines which do not mandate a test dose. So for example, if you see lignocaine or if you see vitamin B12 injection, there the insert would mention that you do a test dose before giving this medicine. So only if it is mandated on the leaflet with the drug that a test dose needs to be given, then only a test dose needs to be given. More importantly, the courts will also accept the fact that even though the test dose was negative, when full dose was given, the patient can still have an allergic reaction. So when we write down that the test dose is showing no allergies, it does not mean that the patient will not have a reaction when full dose is given. So we should prepare ourselves well for this kind of emergency. So my one line answer is no for every drug, yes for drug which mentions, plus even if the test dose says no reaction, patient can still have a reaction.
For that, everyone has to read that leaflet. Medication this day. That is very important because we never read that, be frank with you. We generally we are in a scientifically right way we try to manage, but legally right way we don't know.
I have two cases, sir. I am fighting. One is a pantoprazole death where a diagnostic hysterolaparoscopy infertility young patient was admitted in the morning. Pantoprazole pan 40 drug dose was given and she had cardiac arrest and died. And another case I am fighting is ranitidine injection ranitidine which the patient had received earlier. A cesarean section was done, post-op ranitidine was given and she had cardiac arrest and died. So these two cases I am just now handling in the courts.
Both cases leaflet, it is mentioned the test dose or anything?
No, ranitidine it is not mentioned, pantoprazole also not mentioned.
Okay. Thanks, Manish. I will come back to you. The next is the medication error can happen at every stage. At the 56% time, they happen at the ordering, 6% at the transcription, 34% at the administration. Dose related 28%, route related 18%, documentation 40%, wrong date 12, frequency. So you can start from the physician writing till it get transcript, dispense and administration. So for every level there is a chance of the medication error, and that's what we are discussing since last 2.5 hours. And our next case is related to that. It's to Dr. Jose. This patient was a cardiac, plus she had COVID. She recovered from the COVID. She has a diabetes, hypertension, IHD, recently diagnosed pulmonary embolism. She recovered in a 3 weeks time, and at the time of the discharge, the primary consultant advised on phone to the ward doctor tablet Cardivas 3.125 milligram to add into the drug. On duty doctor written it as a tablet Cardivas 31.25 milligram. Then pharmacist called the primary consultant. He said what dose to prescribe, 3.125 or 31.25. So you can imagine at every level there was this thing. So what went wrong in this case? And the ordering on phone, or there is a specific way when you are ordering, you need to check who is at the other end, or wrong description by the on-duty doctor, who are whether he was qualified, whether he was aware about this thing, and who should be responsible for this type of the errors and how to avoid in our day-to-day practice.
Sir, this error occurred while transcribing telephonic order. So this is a transcription error. And here we all have a policy regarding verbal orders in our hospital. So only during the emergency situations, we can do a verbal order. Here it is the advice for discharge. So it is not an emergency situation. And there itself, the verbal order cannot be valid. So in the verbal order policy, we should define when and where a verbal order can be given and who can give and who can take it down. The verbal order.
More important.
That should also be defined.
Yes.
So as you have mentioned, the qualification of the person who is taking down this verbal order is to be clarified. We have credentialing and privileging for that. So that should ensure that only a qualified person is taking down the medication or the verbal order. Also, we have the readback policy. So if the readback is being ensured, that is 3.125 or 31.125 is different, and if the readback is being done and verified, this error could have been avoided. So the readback policy should be mandatorily be followed, and also the prescriber itself is responsible for this, since he haven't done the readback, and proper training should be given. The cardiovas dose, the pharmacist was well aware regarding that. The 25 is the maximum dose, and 31.25 there is no dose about that. And more training for the junior doctors who have been working in a particular specialty should be given by the senior doctors. And thank you, sir.
You are absolutely right. First thing, it was a discharge, so it was not emergency. No verbal order should be taken. Second thing, one should check who is the taking order, qualification, and this thing. Third thing, again, confirm that key with the verbal this thing. What we know this, every NA-based assessors audit stress on that, every hospital, but it is still repeatedly happening. Will you advise what to do? Because see, this is not a story from my hospital or your hospital or anyone's hospital. This will go on happening. There, whether you do the whether you are NA-based accredited or not, but how to get over this problem? Like, can't say I am busy, I am in a cath lab, you just take over the order. I don't have time to come to the ward and write down that for one order of the cardiovascular, I will not come to the ward which is on the 5th floor and he is in a cath lab on the 2nd floor, something like that. So do you have any any suggestion in a short time? We are running out of time, might be next 2-3 minutes we'll try to finish it.
So regarding verbal order, the first thing is the mandatory training should be given to everyone.
But before that, I will say, shall the ward doctor has a right to refuse that? No, I will not take the verbal order since it is a discharge. You please come and write down or send your research. That's the ward doctor has that right, irrespective of his. Yeah, Gracy madam, you have to unmute. I know, yes. Dr. Machave, everybody wants to answer this question.
No, not only over here, even the management should make it a point. It's not only, we should not leave to the clinician. Management should say, though, in my hospital, this is the practice and you have to abide by this particular rule. If we are not strict, doctors have been taken into granted and nobody can touch them. That should not be there. That's what I just want.
So we should come from the top to bottom rather than starting bottom to top. That's what the my purpose of putting this is.
Yes.
Yeah. So we'll go to the next one and the last question. All of us know EMR is the good answer to avoid this thing. And this was one of the EMR. What I like in this EMR, there's a picture of the patient. So the chances of the error will further reduce. You know that whether it is a pediatric or adult patient, what was the name, and whether he's a male or female. So there will not be the confusion with the age and the sex and everything. So your medication here will further come down. So that's what the, I think, future. And that's the question to the Dr. Machave to end this discussion. Do you agree EMR is the final solution to avoid the medication error? But what about the cost?
Yes, sir. I would agree with it partially, because there are two things. One thing you said about cost, and second thing, again, it requires a lot of training for somebody to use it consistently. For example, it has happened that one of the rheumatologists from Mumbai, he had prescribed, he was giving methotrexate to a lady, and with EMRs in place, everything was going on very well. Now, in a very busy OPD, she just came, waited for quite some time, and because he was busy, the people were giving prescriptions on electronic records, etc. for others. Somebody from outside said, okay, you continue with the same medicine, and instead of taking out a prescription from the software, just wrote down, they always have these notebooks, and instead of having methotrexate once a week, she took methotrexate once a day. And in next 2 weeks landed up with renal failure and landed up with dialysis and all that. So I agree that EMRs would really reduce medication errors, but the issue about cost and training is definitely there. And when we talk about so many doctors all over India, so if we talk about only corporate hospitals or big hospitals, those are not the ones which are serving the common person. There are so many institutes, so many small hospitals. So if we want to really make this a universal phenomenon, the government will really have to have some policy and act on it. So my answer is yes, the problem with training and problem with cost are the two rate limiting factors.
I will add into that. Yeah. Okay, Gracy madam, quick, last 2 minutes.
Here also, I just would like to that 3-letter word what I have used
Yeah, sure.
in the EMR. So then again, that error can happen. We have to be very conscious. That's very important in the EMR and the training.
I would like to add, we are talking only about the cost. We are talking about the training. What about the resources? We should have in fact, there is a wrong concept that the EMR reduces your staff in work. I don't agree with that. If somebody is fooling us that if you use the EMR in the hospital, you will land it with the less staff and you can manage it more effectively. I have the complete 360-degree difference of opinion. We need the more staff. We need the more staff to follow that and meticulously. It will help. It will be the patient safe. It will reduce the medication error. It will help to the staff to just better organize. But it will not reduce the number. And that's what my question was related to the resources. I think everybody will agree with that. There is one question very quickly, Dr. Jose. How are the pharmaceutical errors in telemedicine work?
So regarding telemedicine, also the same with EMR. There are also chances. Verification of a patient is very important when doing this telemedicine. So there are chances of error, and also during prescribing with the telemedicine, errors can happen. With our telemedicine system, our hospital's telemedicine system, it is just a primary one. So once the doctor types the prescription, there are chances of error. There are no drop-down boxes. There are no other features associated, or the telemedicine is not associated with the EMR. So the doctor has to do everything by himself. There, the doctors find it very difficult to type down everything, to note down everything. And there are chances to come with more abbreviations and more errors as well.
Sir, I will just add, sir, the Board of Governors for Medical Council of India on 25th of March 2020 had brought out guidelines on telemedicine. And those guidelines were limited to the period of COVID, and they had made drugs into 3 categories: category A, category B, and category C. So, and very few of the drugs, and there were consultations on video and audio, and everything was there. And this was to work only for 1 year. And after that, the Board of Governors now have a training program for 1 year before you start doing telemedicine. So one has to legally get that program thing done, and then only you should do telemedicine now.
Yeah, and reconciliation is labs over there. That's also there in telemedicine.
Okay, I have to now end this panel discussion because of the time limit. But one of the chat, Anju Benson has mentioned very rightly, to reduce the verbal errors, you can just take a picture and send it to the primary consultant for confirmation. I think that's we all are doing it, and I think that's a very good suggestion. We all should use the social media rather than seeing the WhatsApp in a different way. We can use it in a better way in our day-to-day practice. So
yeah, technology is advancing.
Yeah.
Technology is advancing, and we have to make use of every available.
And we have to be more familiar with that. Don't get shy away, or don't label it as a social media spoils everyone. Social media doesn't spoil. We spoil the social media. Yeah.
One of my laparoscopy patients, where one of the stitch in her umbilicus was remaining, had sent her umbilical photograph to me, and to the amusement of my family, that why patient are sending umbilical photograph. But that is very good, because I realized that one stitch is still remaining and we could call her and get it removed.
So to end this discussion, I must thank my all panelists. I know you want to talk to with more and more your this thing, but if organizers next time allot us 45 minutes, we can have a better dialogue with each other. So error is human. Cover up is unforgivable. Please don't cover up. Discuss with your team, discuss with your management, quality department. Fail to learn is inexcusable, because at the end of the day, patient is paying for that. So for patient safety, it's all of us. We all are responsible. Please share. Develop the blame-free environment, inform culture, and the whole aim should be the patient safety, and patient safety. Thank you. Thank you.
Thank you, sir. Wonderfully moderated, superb panel. And again,
thank you so much.
Kapil, sir, Rebecca ma'am, and everybody for involving me. Thank you so much.
Thank you.
Thank you, everyone.
Over to you, Dr. Radhika.
Thank you, Zirpe sir, for this engaging session, and thanks to all our esteemed